Well, good afternoon again. This is the second half of Chapter 6. Remember, we ended up with salmeterol, which was Ceravent, one of the long-acting bronchodilators. One that came on the market next was formoterol or Foradil or Performist. These are also beta-2 selective agonists. This one was pretty good, and you could see the effects or feel the effects within about 3 to 5 minutes. The thing about this one, though, is that it wasn't a rescue inhaler. This is a very low level bronchodilatory effect, okay? And that's one thing you have to keep in mind. It's going to have to last up to 12 hours. It was available both as SVN and a DPI. It was maintenance treatment for asthma, and as you can see, for exercise-induced bronchospasm, both in adults and children 5 years or older. This was one of the medications that had to be refrigerated. So when you got this, it came in a refrigerated pack, and then you'd have to take it out before you went ahead and did the treatment. Most of these have an anti-inflammatory effect. One of the nice things is when we combine them with the corticosteroids, both of these, the corticosteroids and the beta-2s, actually affect the action of the other one, and we get much, much better results. Brovana is one that's on the market. You can see our formoterol. This is also a beta-2 selective agonist. It also lasts for 12 hours. It only comes as a nebulizer treatment, and right now it's only approved for the maintenance treatments of COPD. When we talk about Chapter 7 is going to talk about the parasympatholytics. All of those drugs are provided for COPD. They work much higher in the airway, where the problem for patients with COPD have their problems. And so that's where they work extremely well. And this one is also another one that does the same. This is a new one, and Dactyrol is a new one that you see. It's a DPI, ultra long lasting. This one's up to 24 hours. And this is another one that's out there just for the treatment of COPD. Aldosterol is another one. This one is 24 hours. This is also COPD. Vilanterol, this one is not available as a monotherapy. Monotherapy means, can you just deliver the vilanterol by itself? And the answer is no, you can't. It has to be used with something else. The fluticasone, the imidinium, the fluticasone and imidinium. This is your trilogy elliptica. Ultra long lasting, does what it needs to up to 24 hours too at this particular point. So what's our problems with these? Any of the long-acting bronchodilators have to be used with an inhaled corticosteroid. We know that if you use them by yourself, what's going to happen with those is we're going to get bronchial constriction, wheezing, and we have a higher mortality rate with it. And as a result of this, remember I told you the FDA had black boxed all of these. They were threatening to take them off the market. They said if you're going to use them, you have to give them with the inhaled corticosteroids. We did that. The black box is gone now. You still have to take them with the ICSs, okay? And as you can see with this, they should only be used if the patient is not controlled with an inhaled corticosteroid by itself. Short term only, that's a very nebulous term. What is short term? A lot of times, once we have you under maintenance, a lot of times we're not going to go ahead and take this away because we don't want the maintenance portion of it to go away also. So remember, when we're talking about the beta agonists, the sympathomimetics, you have 3 different mechanisms of action. You have the alpha receptor, which is your vasoconstriction. This is your epi, your racemic epi. We use this whenever we have things like croup and things along that line. You have the beta 1s. These were the increased heart rate, contractile force. We got to the point where we're starting to decrease the number of beta 1 receptors in especially our long-acting beta agonist. And then the beta 2, this is what we're actually stimulating. This is the relaxation of your bronchial smooth muscle. And there you see, we look at the adenocyclase. This is what we're actually starting to increase the production of, and that gives us a better chance to produce CAMP, and that allows us to get the bronchodilation that we need. The alpha receptor inhibits the release of the neurotransmitters, which is what we need. However, as you can see, it can lower the synthesis of intracellular CAM, which in some cases is not a bad deal, because if it's doing what we need it to do, we need to make sure that we stop at some point. So with the alpha, what we're looking for is vasoconstriction, okay? We're trying to close the vessels down. We use this for anaphylaxis when we have swelling in the upper airway. Remember again, the major one that we use is epi, racemic epi. It is the granddaddy of this whole mess of alpha receptors. What you see on questions a lot of times is you have a patient, has some bronchoconstriction, they have wheezing going on, they call for an epi treatment. Is this appropriate? And the answer is no at this particular point. You're looking for something that's going to give you a little bit longer. If they tell you the patient has upper airway stridor, let's go ahead and give them albuterol. Inappropriate treatment. Albuterol does not work in the upper airways. It does not have the alpha properties. It's only a beta 2. So with these, the lipophilic, these are tending to combine or dissolve with lipids or fats. Remember, this can diffuse into the cell membrane because of the phospholipid layers, and it binds to the area of the beta receptor that we have, and that allows us to get better reaction. How can we give these drugs? There's a number of ways that we can do. The main ones that we do are your MDIs, your DPIs, nebulized, and Resmets. The Resmets are actually newer ones. They've been out for maybe 3 or 4 years. Really nice administration with them. You get to see one of those. Orally, we have tablets and syrup. Remember, tablets take a longer onset and they last a little bit longer. You got to be careful though. You got to make sure your medication is not broken down into the GI system. If it does, then there's tablets aren't going to work. And we can also, for some of these, give them by injection. So sometimes you'll see these orders written. Tributylene is one that we haven't talked about. Tributylene happens to be a bronchodilator. We'll sometimes have these patients with albuterol, leave albuterol, and if they're really bad, your physicians will sometimes write an order for IM tributylene or sub-Q tributylene at that particular point. So sometimes we can do continuous nebulization of albuterol. We see this when you have severe asthma, and we're trying to avoid things like respiratory failure, intubation, mechanical ventilation. Sometimes we're going to talk about BiPAP machines. It seems to help a little bit with this too. It also simplifies your treatment requirements. I remember one Sunday I was working in the ED, and the first 6 patients that we had were getting back-to-back treatments. All of them got at least 3 back-to-back treatments, which meant that I gave a unit dose of albuterol. When we finished that one, we went in and gave a second one. When we finished that one, we went and did a third one. We assessed them between all of these. The ones that were getting better, we'd normally stop after the third one. If they weren't getting better, then we'd add a 4th one, sometimes a 5th one too. Makes it much easier if we're able to do the continuous nebulization. And as you can see, you're going to generally get 10 to 15 milligrams per hour for an adult. Part of the problem you have with adults is they don't like this sometimes, and they don't like it because it's a continuation of the treatment. It's going on and on and on, and they're getting to the point where they're getting tired of it. Kids seem to adapt to it much, much better. And there you see delivery mechanisms. We can refill the SVN. You just go in there and do almost like our back-to-back treatments. You have infusion pumps. You also have large volume nebulizers that you can fill, and that will last you an hour. The problem that we need to do, monitor these patients, make sure we're not getting this negative side effects, okay? Because there's a certain level that you reach a toxic level, and that's what you have to watch for. So what are some of the side effects? Most every medication known to mankind has side effects. The one for our bronchodilators is tremor. Number 1 is muscle tremors. We still see cardiovascular effects, tolerance to the bronchodilator, loss of your bronchoprotection. There's your foam PO2. Toxicity we see paroxysmal or paradoxal bronchospasm, and sometimes people are sensitive to the additives that were in these medications. If you have someone who's doing an inhaler and they're reacting to the HFA or any of the other things that we're using, you can't give them the inhaler. It's not going to do what they need to do. What you need to look at is say, is there something else we can do? Does it come as a DPI? The carrier gas of the DPI is the patient. They're the ones who are expected to get the medication out. Does it come as a ResMat? If it comes as a ResMat, it doesn't have that HFA. It does exactly what it needs to do. If it's going to be an aerosol, the SVMs don't have that. So we can sometimes get the medications without the generic portions of them, without the stabilizers that are in them. They're just the medication. Some of those medications have to be refrigerated, but we do have those medications available. So some of the beta agonists controversies you can see up here: asthma paradox, increasing evidence of mortality and morbidity, regardless, despite or the fact that we're getting better, we know more about it. And some of your questions, are we not using the steroids? Are we not using them in time? Are we losing the effects of these? What's going on with them? One of the things that we see with our patients who have asthma, basically, and we see this with our patients with COPD, but we also see it with our asthma patients, is that sometimes they learn to manage their symptoms and they get into trouble because all the management they do is not working at this particular point in time. If you start to wheeze a little bit, you go grab your medication, you do your medication, you think everything's going to be okay. 20 minutes later, you're still wheezing, but a little bit worse. You go and grab your medication, you do a couple more inhalations, and you know that you're going to get better. You wait another 30 minutes, and you're now much worse than you were before. You go and grab your medication, you do your medication again, and then you go ahead and hopefully by this time someone's called 911 because the medication is not working. And this is where we see a lot of the negative effects. Okay. Another one, temporary relief leading to delays. That's one that we see. We used to see that with some of our patients. We got to see them quite often, and you would ask them, what happened? Well, I knew I wasn't supposed to be doing this, but I really wanted to. And we see this especially with hay fever and things like that. Well, when did you start having problems? Oh, probably about 15, 20 minutes before everything ended. But I took my inhaler. Remember, those inhalers are not infinite. They have a finite dose in them. And if you're using them more often, that doses are going down and down and down. And if you've been using it for quite a while, you can run out of medication at that particular point, okay? So how do we assess these patients? We need to know, what is their peak flow rate? Every person who has asthma should have a peak flow. And like I said, Teresa's working with you guys. You can set and know what your triggers and where your numbers come from at this particular point. We need to listen to these patients. You guys were taught how to do patient assessment. How are they breathing? Are they tripoding? Do you hear wheezing? I'm going to tell you right now, not everything that wheezes is asthma. Not everything that wheezes is bad. If you have someone who's having an allergic response or asthma exacerbation and it's really bad, those breath sounds are like, and you're going, this is not good. That's like a squeaky sound, okay? When you start to hear more wheezing, they're getting better, okay? So you have to understand that. We're looking for an increase of the heart rate of about 20%. If you go 20% over baseline, that oftentimes means you're having an allergic response to the medication. And so at that particular point in time, we're going to stop the medication. We're going to have the patient rinse their mouth out. People go, well, I'm not going to have to rinse their mouth. I don't understand. The medication is still in their mouth. It's still being absorbed. And so we're going to go ahead and have them rinse their mouth out. And when they do, they're going to be able to get rid of it at that particular point. Okay? Subjective reactions, how do you feel? How are things going? You look like you're breathing a little bit easier. You still look like you're breathing much harder. Your work of breathing is still going on. We need to talk to them, okay? One thing, and you're going to hear this again, is don't put words in the patient's mouths. Okay? If you go in there, you're looking at these patients and you need to ask them, how are you feeling? How are things going? They may be using a lot of accessory muscles. They may still have a little tripoding going on. They may have some other things that are going with it. And you can say, man, you look really bad. You must really, really not be breathing well. Guess what they're going to tell you? I'm really bad. I'm not breathing well. Or they may have told you, I'm beginning to feel a little bit better. Okay? So do not put words in their mouth. They will adopt whatever words you give them. We can do ABGs, see how well you're getting. We are going to monitor your glucose and your potassium. Albuterol we use on occasions to decrease high potassium levels. So we need to watch and make sure that that's working out for us. PFTs, remember you're going to set your baseline PFTs when you're feeling the best you can be. That's how you set your goals, okay? Patient education, patient education, patient education. Not only the patient, the family, whoever they live with, the caregivers, whoever's there. Let's talk about this. Let's talk about how you give this. Let's talk about when do you give this. Let's talk about the asthma action plan you're going to help make. Let's go ahead and make sure that everybody is educated, okay? I remember one time they were talking about this child who was having all these exacerbations, and the therapists at that time were able to go out and see what was going on. Well, the child was allergic to mold and mildew. His bedroom was in the basement. And what do we have in the basement? Mold and mildew, plus carpet. Okay? Carpets are horrendous for people who have asthma because of all the mold, the mildew, the dust, and everything else in them. And so the therapist went out and told the family, he can't have the basement bedroom. Well, he wants to be a big boy. He's got to sleep somewhere. That is not patient education taken to its finest, okay? The therapist talked to that family and tried to explain to them what was going on. And then, do they know how to use these devices? Do not let a patient get away with, I've used them for 20 years, I know how to do them. You're going to stand there and say, then show me. Show me how you do this. I want to make sure that you're doing this appropriately. And you'll be surprised at what you're going to see them do. Sometimes they're using these and they're doing, okay, I've used my 2 puffs. That's not how you do it, okay? You have to look at these patients, make sure they know what they're doing. What else are we going to do? Ongoing lung function. We can do serial PFTs if we need to. How many times do they have to use these rescue drugs? If you're using your rescue drugs with your long-acting beta agonist, you're not under control, okay? Nocturnal symptoms. I still wake up in the middle of the night. You're not under control. We need to take a look at what's going on. How many exacerbations have you had? How many days have you missed from work and school? We're not only looking at how many days the patient has for kids, we're looking for how many days have those parents lost days. That's lost from the workforce also. And you have to realize that sometimes people will go, if you're sick, absent 1 or 2 more days with your sick child, we're going to have to replace you. I'm sorry. That is a valid threat because a lot of these companies cannot afford to lose their workforce. Okay. And then can we reduce the dose of our inhaled corticosteroids? At one time, if we increased your corticosteroids, you stayed where you were. As it is now, we know that we can back up a little bit. And if we can back up a little bit, that gives us some breathing room at that particular point in time.